So when we talk about anticipating and preparing, we have to identify the risk factors, what is expected gestational age. So in preterm babies, as we will discuss later, there are specific steps. Is the liker clear? Are there additional risk factors? What is the cord management plan? And some newborns without any apparent risk factors will require resuscitation. Every birth should be attended by at least one qualified individual who can initiate resuscitation, whose responsibility is to manage the newborn baby. So sometimes the midwives in the labor room may be managing the newborn, but they should be able to call the NICU nurse and the doctor for help immediately. If there are risk factors, at least two qualified individuals, usually the NICU nurse with the NICU doctor, will be present solely to manage the baby. The risk factors will decide how many of these. For example, twins or triplets, you need more. A qualified team with full resuscitation skill should be identified and immediately available. They should be present at the time of birth if advanced resuscitation is anticipated. So don't delay calling them, because the equipment check also needs to be completed. There are multiple risk factors that increase the likelihood of neonatal resuscitation being needed, but there are also some situations where you may not anticipate and the baby comes out flat. So labor is not predictable. You can review my lecture on perinatal asphyxia to understand how these factors play a role. So antepartum factors: prematurity, post-maturity, preeclampsia, eclampsia, maternal hypertension, multiple gestation, fetal anemia. Polyhydramnias, oligohydramnias may indicate underlying birth anomalies as well. Fetal hydrops, fetal macrosomia, intrauterine growth restriction, significant fetal malformations or anomalies, and no prenatal care becomes a risk, because any of these could exist in the absence of prenatal care and you may not know. Intrapartum risk factors: emergency cesarean section, forceps or vacuum delivery, breech or abnormal presentation, fetal heart rate abnormality category 2 or 3, maternal general anesthesia, maternal magnesium because the baby may come out floppy, placental abruption, intrapartum bleeding, APH is a possibility and asphyxia is associated, chorioamnionitis, maternal sedation, especially with opioids, within 4 hours. But remember that the sedation effect can persist longer in some mothers. We cannot predict the metabolic pattern, and so sometimes I've seen sedation even after 8 hours. Shoulder dystocia, meconium stained amniotic fluid, and prolapsed umbilical cord. So most of these are conveyed by the obstetric team. As I said, you have to be prepared for a situation where you may not be able to anticipate. The fetal heart rate changes are there in a separate video as well. You can search on my channel. In terms of the pre-resuscitation team briefing, we have to assess the risk factors, identify the leader, which in usual situations is quite clear-cut, anticipate potential complications. So suppose you have twin pregnancy in a premature baby pregnancy, you have to prepare to give surfactant, be ready to intubate if needed, and so on. Most of the time we don't bring surfactant to the labor room unless it's an extreme preterm, because the prophylactic surfactant concept has changed, and most of the labor rooms are situated next to the NICU, so you may be able to get the surfactant soon. Otherwise, we can stabilize the baby on non-invasive ventilation, take to the NICU, assess and decide on surfactant. Delegate the tasks, identify who will document events as they occur, determine what supplies and equipment will